Today I'm going to actually present an extra special case. We have a special guest, Dr. Paulson, who's one of our attending pathologists here. And the case is called When You Hear Hoofbeats. And let's get started. So first for the case presentation, we have a 61-year-old male, history of Crohn's disease, status post multiple surgeries. I know that's probably not the standard Mount Sinai way of describing Crohn's disease, but it's less relevant to this case. He also has MDS. He had a stem cell transplant. He's coming in with painless jaundice. On labs, CBC relatively unremarkable. He has a little CKD on his BMP, and his liver enzymes are elevated: AST 154, ALT 298, Billy 12, ALK Phos 475. Imaging shows a markedly distended gallbladder, common bile duct dilation to 1.5 centimeters with an abrupt termination in the pancreatic head. And in the pancreas, fullness in the head, no frank mass, no obvious PD dilation in this first imaging. So based on the jaundice and the imaging, he goes for endoscopic ultrasound and ERCP. On the EUS, he has, as noted, common bile duct dilation to 13 millimeters. The PD is like borderline dilated, 3.5 millimeters in the head. And he has a mass seen in the pancreatic head. So it's about 2 by 3 centimeters. He undergoes fine needle biopsy. On ERCP, he's noted, you can see on the image to the left, he has a distal common bile duct stricture, and he has a metal stent placed. And now, Dr. Paulson, if you want to flip on, we're kind of going to tag team this so that we can describe the pathology.
Sounds good. So I'll share my screen.
Perfect.
Okay, good morning. I'm John. So I'm glad to be here this morning to show some histology of this interesting case. So this is the first biopsy. This is the biopsy in its entirety. And when we take a look around, the biopsy in some areas just shows completely benign pancreatic acinine. This is benign pancreatic acinar tissue with grape-like arrangement of the acinine. And some fragments are completely obscured by this pink fibrosis. This piece looks a little bit more busy, and that's because the tissue is completely infiltrated by acute inflammation, or neutrophils. And when we look higher power, we can see these neutrophils percolating throughout the tissue. And this fragment really has the key diagnostic feature for the histology, and that is a granulocytic epithelial lesion, or GELs as we call them. And this is a histologic feature that characterizes type 2 autoimmune pancreatitis. So what is a GEL? A gel really is just a complex of the pancreatic ducts with neutrophils, and they can have several appearances. Like here, basically the pancreatic ducts are packed full of neutrophils, or intraluminal microabscesses. And occasionally, the neutrophils creep into the duct epithelium, disrupt it, and damage it. It's very reminiscent of what we see in IBD when neutrophils invade the intestinal crypts. And in fact, type 2 autoimmune pancreatitis is associated with IBD, and our patient has IBD. So it's starting to look like this is type 2 autoimmune pancreatitis. But that's sort of secondary. My job when they see a mass is to make sure that there's no malignancy in this biopsy material. These ducts are a little bit atypical, but they are being aggravated by neutrophils. But we do stains for tumor suppressor SMAD4 and P53, and this was indicating these are benign ducts. And when talking about autoimmune, we also do IgG4, which was negative. So just to get our bearings for autoimmune pancreatitis, there's 2 types. Type 1 is the type that really the prototype one we think about, has the IgG4 association, has the storiform fibrosis, and lots of plasma cells. And type 2 is really a different creature. It's what we're seeing here with the gels, the neutrophils, and association with IBD. So I signed out this case. I described the histology and said suggestive of autoimmune pancreatitis type 2 in the appropriate clinical setting. I also have a little note down here, but I don't want to spoil anything, so I'm going to leave that out for now before we go into the second biopsy. So that's biopsy number 1.
Thank you, John. That was perfect. I'm going to steal the screen now. All right. So based on that biopsy and the presumptive diagnosis of autoimmune pancreatitis, the patient was started on prednisone with the standard treatment for autoimmune pancreatitis. He stayed on that for 4 or 5 weeks. He had a repeat imaging. There was still some fullness in the pancreatic head, but maybe less conspicuous. The biliary tree was decompressed adequately by the stent, and his labs improved. So his bili came down, AST, ALT, alk phos came down. Notably, IgG4 was normal, although this is basically what you would expect in type 2 autoimmune pancreatitis, which is what we suspected. So he began tapering his prednisone, and then he came back for repeat ERCP for stent exchange or stent removal, and another EUS to assess the pancreas mass that we saw last time. So on the EUS, actually there's been some progression in some areas. The pancreatic duct was more dilated. Last time was 3.5, now it's 4.3, and it was 2.9 in the body, which is again a little bit above what we would expect in the body of the pancreas. And there's still a persistent mass. It's maybe a little hazier in this picture. Sometimes that's just imaging quality, but it's definitely still present, notable. I do not have ERCP pictures, but based on his improvement and the expected response to steroids, that metal stent that we placed last time was actually removed. And now, John, you can go back for biopsy number 2.
All right, so biopsy number 2. So this is the biopsy in its entirety. And when we take a look around, we see some similar findings that we saw before. We have some fibrosis, and then these neutrophils or acute inflammation infiltrating the benign pancreatic tissue. And in this fragment here, lots of fibrosis. Something we didn't have last time was fat necrosis. And we were talking in the department about this. Why would there be fat necrosis in this biopsy? Fat necrosis is not associated with type 2 autoimmune or type 1 autoimmune pancreatitis. So one of the things we thought about is this could be due perhaps to prior biopsy effect. So really non-specific findings. We don't have any gels here, but some similar findings. And Dr. Harpman has actually signed up this case. So acute and chronic pancreatitis with fat necrosis, and this fat necrosis could be contributed to prior biopsy. In the correct clinical setting, this could be associated with type 2 autoimmune pancreatitis. It's really non-specific, but importantly, no malignancy in this biopsy material either.
All right. Now back to the case. So based on the fact that he still had the presence of the mass, he still had biopsy evidence of autoimmune pancreatitis, he was restarted back on prednisone 40. So the taper was brought back up to the standard dosing to see if we could get this better. And then after only 2 weeks this time, he had repeat labs, and he just had everything had gotten worse. Unfortunately, he got more jaundice. His bili was up to 9.6. Alk phos was over 1,000. Everything was worse than it ever was. So he came back for, again, repeat ERCP EUS. On EUS, he has really a more distinct head of pancreas mass at this point. You can see this hypoechoic mass here. And he had another fine needle biopsy. ERCP, again, a very, very tight stricture in the distal common bile duct. He has stenting. He actually had a little pus in there as well. So John, you can take us through the final path.
All right. So this is the third biopsy in its entirety. And when we take a look around, we see here some very atypical cells. They're irregular nest, and the stroma is desmoplastic, has this hazy blue look to it. And the cells are very atypical. Looking high power, we see the atypical nature of the nuclei. They're hyperchromatic and squished. And the cytoplasm is also atypical, very foamy. And there's some single atypical cells as well. Immunostains for SMAD4 show loss of tumor suppressor SMAD4 and overexpression of p53. This is very clear-cut pancreatic adenocarcinoma. So it's invasive, moderately to poorly differentiated adenocarcinoma in this pancreas mass biopsy. It's also a bile duct stricture biopsy, showed exactly the same morphology, cancer in the bile duct stricture as well. Nick, do you want me to go into this study now?
Why don't you explain this part first? Yeah.
Great. So this is a reference actually cited in the first biopsy report. It's a study that's done at Cleveland Clinic and University of Chicago. And it explains basically that pancreatic ductal adenocarcinoma can have autoimmune-like histologic features associated with it, both around it and amidst the tumor. So it was a study of 105 resection specimens for pancreatic ductal cancer. 65 of them showed chronic pancreatitis, and 10 of them had autoimmune features. And the conclusion of the paper basically was caution is necessary when making a diagnosis of autoimmune pancreatitis by needle biopsy of a mass lesion. And patients with a tentative AIP diagnosis should be closely followed up clinically, which the clinical team did wonderfully. And here's a table 2 from that paper showing the different AIP features that you can see in pancreatic ductal adenocarcinoma around it and both within the tumor. Most of these cases had extensive pancreatitis, and half of them actually had gels like we have. So the gels can actually, when we get the resection specimen, we'll probably see gels involving benign epithelium and the cancer as well. So it'll be interesting to take a look at that. So back to biopsy 1. So because Dr. DeMeo and Nick saw a mass, just sort of cover bases or cover tail, we mentioned that 10% of pancreatic cancer can be associated with these AIP features. So this is just yesterday from the gross room, the gross respection specimen from this patient. We can see that there is white firmness within the pancreas. So down here is the plique circularis of the duodenum, and this is the pancreas. This yellow ink is the common bile duct. So we have this firm lesion here, pancreatic cancer, that's involving the common bile duct. And here in the background, you can see the lobular benign pancreas, more yellow in color. So the slides aren't out yet, but we'll probably see perhaps some remnants of the autoimmune pancreatitis, but definitely cancer.
All right, fresh off the presses. Thank you for that update. We will await the final resection specimen. I have just a couple extra learning points to go through, so I'll share my screen again. So I think the big overall teaching point and takeaway from this point, this presentation, and the reason I called it When You Hear Hoofbeats, is that this patient presented with painless jaundice and a mass in the pancreatic head. So you always have to think there's malignancy. Your suspicion for malignancy should be very high. And despite a couple red herrings, you know, the IBD, the unusual biopsy, he didn't respond to steroids, and persistence eventually proved that he did have cancer. And so I'll just share a couple. We went through the pathology that can help differentiate autoimmune pancreatitis, or sometimes be a little confusing in cancer versus autoimmune pancreatitis. I'll present a couple clinical elements that can help differentiate autoimmune pancreatitis from pancreatic adenocarcinoma. So here's a few, like a table that sort of breaks them up by different criteria. First of all, imaging, which we'll look at a picture, but in autoimmune pancreatitis can often look like diffuse enlargement of the pancreas with a capsule-like rim. And the features of pancreatic adenocarcinoma you might expect are a mass, although that can be seen in either one. The key differences with cancer are you're going to see duct dilation or a duct cutoff and upstream atrophy. And so one of the red flags in this case was that he had progressive duct dilation on EUS, and that's a little more suggestive of malignancy rather than autoimmune, where you might expect a normal duct. On serology, if it's type 1, you might have an IgG4, although we suspected type 2, so that didn't necessarily help us in this case. And similarly with pancreatic cancer, you might see an elevated CA19-9, although that can be elevated in many forms of sort of pancreatic biliary disease, especially with biliary obstruction, as in this case, so that wouldn't have necessarily guided us either. Here's just an example of those imaging characteristics I was talking about. So on the upper image A, you can see this just diffusely enlarged pancreas and that hypoechoic capsule. Slide B is a more subtle form with just focally enlarged pancreatic tissue, but no duct dilation or atrophy. And in C, you can see, you can't really see the mass, but you can see this mass in the body. Here, I'll point it out. This hypodense mass, and then this is the dilated duct, and there's just atrophy of the pancreatic tissue upstream. So that's more suggestive of malignancy. Other clinical features are in autoimmune pancreatitis, they may have involvement of other organs, especially in type 1. So they can have diffuse IgG4 related disease, including biliary strictures, renal involvement, retroperitoneal fibrosis, or parotid or lacrimal gland enlargement. Type 2 autoimmune is often associated with IBD, as we know. And unfortunately, again, in this case, that was another red herring. A patient did have IBD, but he didn't have autoimmune pancreatitis. So pancreatic adenocarcinoma, obviously you would look for METs. You're never going to see METs in autoimmune pancreatitis. And lastly, and I think the most important in this case, is response to steroid treatment. So autoimmune pancreatitis tends to respond very well to steroid treatment, especially type 2. and pancreatic adeno is not going to respond. So that was really the clincher in this case. And that's it. Thank you.
Does anyone have any comments or questions? For me, that was, first of all, thank you for a great presentation. And John, thank you for the excellent path slides that you showed. For me, the second EUS, whether after the patient had been on steroids, that was really a big red flag that you still had a mass there. There's really no response to the steroids. You still had the, even worsening pancreatic ductal dilation, that, this is not just AIP, and our awareness has to be heightened for pancreatic adenocarcinoma. Any other comments, questions for this case? It was a great case.
So I'll just chat. I'm sorry, guys. Go ahead. Go ahead.
The reason for putting in a metal stent, maybe I have the wrong impression in my head, but I would have thought it might have been a plastic stent because we thought it was going to be a temporary thing until he got better on steroids. Or can you guys help me understand that?
Yeah, I think either would be appropriate in this case. Chris may be able to comment more, but I'll note I didn't mention, it was a covered metal stent. So it was not a permanent stent. So we did actually remove it after a few weeks. And Chris, I don't know if you have more comments about that specific choice.
Yeah, and I'll echo the sentiments. Thank you both for phenomenal presentation. So when I first saw this patient, when I did the first endoscopy, I came out and told the patient and his wife that I think he has cancer. And our suspicion was so high up front during the initial EUS that we put in a fully covered removable metal stent. The thinking being that if he was going to get some type of chemotherapy, he wouldn't need to come back for a stent change before surgery. So that was the thinking there, but you're absolutely right. Plastic stent would have been just as reasonable. And then, as has been pointed out, the two red flags for me were that after the steroids, his labs never really got normal, and the mass or fullness went away. And that's not typical for autoimmune pancreatitis. Usually these patients have a rapid response to steroids, so much so that if the suspicion is high up front, we often won't even put a stent in. You'll give and the biliary obstruction will go away. And that was really the tip off to all this. On the third round of endoscopy, we took the stent out at endoscopy number 2, and then like 10 days later, he was jaundice. I put him right back on steroids, and he did not get better. He just sort of progressed right through it. And it was pretty evident on the third endoscopy that that there was something other than autoimmune pancreatitis going on. And the other point I'll make real quick is that with the two different types of autoimmune pancreatitis, as keeps getting mentioned, type 2 is the one associated with IBD, but it's been pretty well published, and it's been our experience that type 2 present with obstructive jaundice. It typically presents more as a recurrent or smoldering pancreatitis, meaning patients present with acute pancreatitis, they never really get better, and it just sort of lingers for weeks and months. Well, this wasn't the case. So it would have been a very atypical presentation of type 2 autoimmunitis. And again, in our experience with the type 2 IBD, it's usually younger people in their teens, say 40s, is the more classic population. So, I think Nick said it best: when you hear hoofs, think horses and not zebras, because 99% of the time somebody comes in with panc mass and jaundice, it's going to be cancer. Autoimmune pancreatitis is just relatively rare.
Nikhil, can I say something?
Of course.
Nick and John, great. It was a great presentation. That's an amazing case. Chris and I share a young patient with type 2 autoimmune pancreatitis and distal colitis, actually, and it's been really interesting to watch him because it has all the features that Chris just said. His pancreatitis sort of smolders along at times. But I think the key to this whole thing was the non-responsiveness to steroids, and good for you guys for being persistent, and keeping after this and ultimately getting to the diagnosis. What happened to the patient? Like, there was a whole roller coaster for him, right? Chris, you told him he probably had cancer, then he sort of didn't have cancer. Like, how did he take all this?
So, you know, we normally, so initially, you know, I said, I think you have cancer. The biopsies came back. We were all very happy. And after the first round of, I really thank Dr. Paulson for putting that note in the original biopsy result, because I told the patient and his family after the biopsies came back, I said, it looks like autoimmune pancreatitis. We need to keep like a 5% suspicion that there's something else going on. So that was really key for me. I think I've heard this, maybe like a case report from Japan about this phenomenon of AIP type changes in pan cancer. So I planted the seed with the patient, and then I just sort of kept them at bay the whole time, that I don't think we're completely out of the woods. This is Peter Rubin's patient. I don't know if he's on the line, but you know, he appropriately, he's been around a lot longer than all of us. He appropriately said, are you sure we're not missing cancer? Are you sure we're not missing cancer? And again, I said, you know, we're keeping it in the back of our mind. All of the evidence we have is that there is, but has been pointed out, the labs never really got better. The mass, the fullness never really got better. And that's really atypical for autoimmune. So, you know, this is a collaborative effort in this case. And I think the pathology team really helped keep us on alert that we can't rest on our laurels and just say, well, why aren't steroids working? Well, and I think, and you know, John, maybe you can comment. You know, there's this other phenomenon as autoimmune pancreatitis started to become more recognized, that the tumor itself can just cause inflammatory changes, autoimmune or not. And sometimes you give steroids and those peritumoral inflammation goes down, and it actually makes the mass more evident on imaging or EUS. And I suspect that may have been the case here, but I don't know if you have any comments on that.
Yes, absolutely. Sometimes even in biopsies of pancreatic cancer, we can see an acute pancreatitis associated with it, and due to the damage it's causing to the ducts, absolutely. And I can imagine after giving steroids, I don't know what we'll see in the resection specimen, but the resection will be very interesting to see what we see, if we do see residual autoimmune-like features or not after the steroids.
On the second specimen, there was a comment about fat necrosis. Can you talk a little bit more about that?
Sure. Fat necrosis is not something that we see histologically associated with autoimmune pancreatitis. We usually see it more with like alcoholic pancreatitis. So that really, you know, it made us question whether or not this patient had autoimmune pancreatitis. But because the patient was biopsied, it could definitely be due to biopsy trauma. We occasionally do see, and I talked with Dr. Zhu, he used to be a pancreatic pathologist here, and he says sometimes in biopsies where the patient's been biopsied a couple months before, you can see fat necrosis due to biopsy passes. But it's very unusual in autoimmune.
Nick, thanks for this great learning case. I just have a question. What do you think the difference in the diagnostic yield on the third time around? Was there anything different that you guys did, like biliary biopsies as opposed to just mass core biopsies, or was it just random?
It was all the same. It was just repeated efforts, I think, and getting enough tissue. And then perhaps, as we were talking about, as the inflammatory aspect of it went away with steroids, maybe that helped make it more clear. I don't know, Chris, if you have any other thoughts?
Yeah, I don't have a great answer, because we took core biopsies all three times of the same exact area. So I don't have a great answer. We did on the third round take bile duct biopsies at ERCP, which confirmed the diagnosis. The core biopsies made the diagnosis on the third. Second biopsy came back. You know, I spoke with John and Noam, and I said, you know, what is this? Is this consistent with treated autoimmune pancreatitis? Is this, you know, and because there weren't the GELs at that point. So it seemed like the autoimmune features were going away or improving. And I don't know. I don't have a great answer. This case scared me. We see obviously a lot of both diseases here. And this is the first time I've ever seen this presentation of this or combination. Very scary.
Really interesting case. Yeah, I'd actually gotten a call about this patient after they got their repeat CT scan, and they had recurrent jaundice, and I looked through the case, and so it's really interesting to see the follow up and what the results. I used to do pancreatic cancer research at one point, and one thing that we were always looking at is how a lot of the tumor actually is this immune infiltrate and how that might drive the pathogenesis. But I've never seen this clinically, so it's really, really interesting case and good learning point to keep our eyes open if we see this again.
Great. Thank you both for that. Really great case and great teaching and learning points. Two things before we switch over to our next presenter. We're going to do a hard stop at 7:55, and I just put a link to our grand rounds in the Zoom chat. It's going to migrate over to a UC Health Zoom for our grand round speaker, Dr. Samir Gupta. And then secondly, welcome to Jerry, who has joined his own conference, the longest running endoscopy conference in the country. So let's switch over to our second speaker this morning, who will be Dr. Christina Wang. Dr. Christina Wang, and if you can share your screen.
All right. Hi, Jerry. We miss you. All right. Can you see my screen?
We can.
Okay. Hey, everyone. I'm one of the second-year fellows. The case I'm going to present today is a 74-year-old male with a history of hypertension, prostate cancer on Lupron and Casodex, previously received radiation back in January 2019, has non-ischemic cardiomyopathy, coronary artery disease, DVT on apixaban, who was initially admitted for management of decompensated heart failure with his hospital course complicated by 3 episodes of bright red blood per rectum, for which GI was consulted. On assessment, he denies pain associated with passage of blood, diarrhea, abdominal pain, nausea, or vomiting. He's never had rectal bleeding in the past. His vitals are stable, but his labs are notable for a hemoglobin drop from 11.6 to 10.4 around the bleeding. His INR is 1.8, and his rectal exam did not reveal any hemorrhoids, but was notable for red tinged stool. We then performed a colonoscopy, and the rectal mucosa was notable for this pale, friable, edematous appearance, as well as these distinct telangiectasias, which can be multiple, large, and serpiginous, consistent with mucosal features induced by radiation injury. In certain cases, strictures, ulcerations, fistulas, and areas of mucosal hemorrhage can also develop in the rectum. Based off of these findings and the lack of alternative causes to explain his hematochezia on completion of the full colonoscopy, his rectal bleeding was felt to be secondary to radiation proctopathy, which we subsequently treated with the application of argon plasma coagulation. Let's speed things along in the interest of time. So today I'm going to speak a little bit about chronic radiation proctopathy, which is simply defined as epithelial damage to the rectum from radiation that is associated with minimal or no inflammation. Oftentimes you'll hear people refer to this entity as radiation proctitis, which is in fact misleading since it inaccurately implies a chronic inflammatory condition of the rectum. Chronic radiation proctopathy occurs in up to 20% of patients who receive pelvic radiation. It's characterized by this obliterative or ischemic end arteritis of the submucosal arterioles, submucosal fibrosis, and neovascularization. It usually manifests as rectal bleeding about 8 to 12 months following radiation treatment, but symptoms can occur at any time up to 30 years after exposure. Other symptoms include obstructed defecation due to strictures leading to constipation, rectal pain, and urgency. The likelihood of development of radiation proctopathy is associated with both radiation-specific factors related to the dose, area of exposure, and method of delivery, as well as patient-specific factors. The management of radiation proctopathy can really be bucketed into three broad categories: endoscopic interventions, which we'll talk a little bit about today; medical therapies, which include sucralfate enemas, short-chain fatty acid enemas, metronidazole, sulfasalazine, hyperbaric oxygen; and finally, surgery when endoscopic and medical treatments have failed. Unfortunately, there have been no large controlled trials evaluating the treatment of radiation proctopathy, and as such, experience is derived mostly from case reports and small clinical trials. In 2019, ASGE actually published a guideline that focused specifically on the available endoscopic interventions that can be utilized in the treatment of radiation proctopathy, and as such, I thought it would be useful to review this today. Starting with APC, which is the most widely available and one of the most popular interventions for radiation proctopathy. It involves short, non-contact applications for 1 to 2 seconds of ionized argon gas, which is applied to the target tissue through the tip of the probe. When treating these lesions, you should focus on a targeted approach and try to avoid painting the surface, which will create more extensive ulceration and increase patient discomfort. Caution should be taken especially with anticoagulated patients, as subsequent ulceration can lead to significant bleeding. The most common APC-related adverse event is pain, which can be related to either ulcerations caused by the treatment or excessive bowel distension from the instillation of argon gas. Other adverse events include strictures, fistulas, and perforation. Colonic explosions have been reported in 2 poorly prepped patients who had only received an enema prep before APC, and as such, adequate bowel preparation is needed before initiating treatment. In this guideline, a systematic review was performed on 33 studies that reported the efficacy of APC for rectal bleeding on a total of 950 patients with chronic radiation proctopathy. A pooled analysis of these studies found an overall clinical success rate of 87% utilizing APC. The average number of treatment sessions for APC to achieve bleeding control ranged from 1 to 3.7, with the time interval between treatment sessions ranging from 2 to 8 weeks. But most studies reported a 3 to 4 week interval to allow enough time for the injured mucosa to heal. One study directly compared APC to BiCAP for the treatment of radiation proctopathy and found it to be equally effective. The randomized study involved 30 patients with recurrent rectal bleeding and found no significant differences in clinical success, which they defined as the eradication of all telangiectasias, no significant difference in mean number of sessions needed for eradication, and no significant difference in relapse rate of rectal bleeding during an average follow-up period of 12 months. However, a higher rate of bleeding from ulcers was noted with BiCAP as compared with APC. Formalin is another intervention in the treatment of radiation proctopathy, and it can be applied endoscopically or instilled by our surgical colleagues. It acts only on the superficial mucosa, resulting in rapid deterioration of mucosal blood flow and coagulation necrosis. Several small studies have demonstrated an improvement in bleeding with formalin application. However, there are only 2 studies that directly compared the effectiveness of APC with topical formalin. The first was a cohort of 25 patients with rectal bleeding, with clinical success defined as an improvement of hemoglobin by 10% or normalization of hemoglobin. 79% of patients had clinical success with APC compared with 27% treated with formalin. The average number of treatment sessions was similar between both APC and formalin. However, the APC group had fewer adverse events defined as nausea, vomiting, rectal pain, and fever compared with the formalin group. The second study involved 30 patients with intractable rectal bleeding, meaning they had at least 1 episode per week or required blood transfusions or both. Bleeding cessation was seen in 94% of patients treated with APC versus 100% of patients treated with topical formalin. There were no significant differences in the efficacy and durability of bleeding cessation between the two groups, and both treatments were well tolerated without any adverse events. Based off of these limited comparative studies, ASGE currently recommends against the use of formalin compared with APC because of higher adverse event rates with formalin. However, the recommendation is conditional with the quality of evidence being low. Finally, radiofrequency ablation, which is well described for the treatment of Barrett's, has also been employed in radiation proctopathy. The depth of penetration ablates the epithelium in the muscularis mucosa without injuring the submucosa, thereby restricting treatment to the superficial surface and avoiding deep tissue injury, as opposed to APC, where multiple applications can lead to deeper levels of injury, resulting in ulceration. Within the systematic review were 3 case series involving a total of 66 patients that examined the effectiveness of RFA in radiation proctopathy. The largest study consisted of 39 patients with rectal bleeding who had failed prior medical therapy. Rectal bleeding improved in all 39 patients with a pre-RFA hemoglobin level of 11.8, post-RFA hemoglobin level of 13.5, after an average of 1.5 sessions and a 12 to 16 week time interval between treatment sessions. There were no reported serious adverse events in this series. Unfortunately, at this time, there are no comparative studies or randomized trials to evaluate the effectiveness of RFA for radiation proctopathy. To summarize, APC, BiCAP, heater probe, and RFA are suitable options in the treatment of bleeding from radiation proctopathy. However, there is currently insufficient evidence to recommend one intervention over the other. I'd like to now open up the discussion to the group to see what others have utilized in the treatment of radiation proctopathy, especially in cases of recurrent bleeding in patients who have undergone prior applications of APC.
Thanks, Christina, for that presentation. Anyone have any comments, questions on therapies for radiation proctopathy?
I could share a case. We had a case of refractory APC that we did RFA on, and it worked great. Patient tolerated it well, and I think we only had to do 2 treatments, and it kept him out of the endo unit. His hemoglobin went up. Same thing, similar as what you reported. I think we've also all used RFA for GAVE, for bleeding GAVE, and that's also been refractory to APC or other therapies. So it's safe, it's pretty easy to use, seems to work well.
Hey, Nikhil.
Okay.
It's Dave. Christina, thanks for clarifying proctopathy versus proctitis. But the most important thing here is Jerry's waving his hand. So call on Jerry, please.
Hi, Jerry.
At the beginning, I was the only one who had an APC in this tri-state area. And there were a lot of patients having bleeding from radiation proctopathy, and I was able to treat a lot of patients. So I had a tremendous experience with using APC. I caution one thing though. One day, a patient was transferred to my office from Brooklyn with severe bleeding from what was thought to be radiation proctopathy. 6 guys brought him into my office, and he was obtunded. I put the scope in and saw, all I saw was stool. So I asked the guys who came with him what kind of prep he had. So they said he was so out of it that he couldn't drink any of it. So I scrooched around with my scope and saw underneath all that stool was a lot of bleeding. And it was obvious from radiation. So I thought, well, what the hell? He's here and I'll give it a try. Maybe I can do something. So I washed a little bit of stool off, and the first application of APC, I heard an explosion. And, instead of looking in the rectal mucosa, I was looking at the floor with the scope. And I was sure that I had exploded this guy. So one thing that you have to keep in mind is, even though you're just going to treat the rectum, you have to clean the whole patient because there was a lot of obvious explosive gases inside that I hadn't done anything with. This was long before we used CO2. So I cautiously looked inside, and actually there was nothing, there was no damage inside. Fortunately, I was only in an inch or two, and the explosion caused the scope to be blown out of the rectum instead of blowing up the rectum itself. So I was really invited over to Cornell University, to Cornell Hospital, to speak before the radiation oncologists, because they wanted to see what this new therapy was. And actually, we did very well and put the treatment of APC on the map. I caution one thing: you don't just put formalin in the rectum, because there was some patients that had that, and reports long ago that you can shrivel up the rectum by putting formalin in. What the surgeons do is they put 10% or even 1% formalin on gauze strips, and through a proctoscope lay the gauze strips on the mucosa and leave it there for 10 minutes. So you don't just put formalin in the rectum and expect it to work. That's enough.
That was awesome. Thank you, Dr. Waye, as always.